It's so exciting that people want to watch a show that's medically accurate. Let's watch episode 4 of The Pitt. Let's get started. Whoop.
When I extubate, we're going to suction the back of his throat. We're going to give him some glycopyrrolate drops, which will cut down on his secretions.
That's part of what we call the comfort care order set, where we probably don't have papers anymore. But back when I was a resident, we have a set of papers with check boxes that already make you think about the potential discomfort that can come with being extubated. Secretions, pain, air hunger, etc. And you have check boxes for the medications you want to use, don't want to use, and obviously alternatives.
We'll get morphine for any pain, and we'll give him some oxygen in his nose as a comfort measure.
And turning off the alarms is a must. It only fuels anxiety.
I don't think that I can do this. I just thought that it would be different. And I thought that we'd have more time.
Is your family religious?
Calling a chaplain really helps in these situations.
No, God.
There's religious chaplains.
I had a teacher, a mentor, who told me about a Hawaiian ritual called ho'oponopono, or the 4 things that matter most. It's basically just a few key things that we can say when we're saying goodbye to a loved one that can really help at the early stages of loss.
What are they?
I love you. Thank you. I forgive you. Please forgive me.
Sometimes when it comes to medical care, giving some sort of instruction, something to say, something to do, something to take, some activity to take part in, is enough for our minds to feel like we're part of our treatment plan and therefore feel less emotion about it. So part of my training with residents is training them to be able to understand that patients have concerns and are coming in trusting that the doctor will do something, even if it's not a miracle, even if it's not gonna make a huge impact, but doing something, asking them to participate in their own care goes a long way and actually improves outcomes.
Mr. Spencer, I'm gonna take this tube out of your throat now. What I want you to do is to take a very deep breath, breathe in, and now blow it out. There we go.
Suctioning of the throat's really important because it's very uncomfortable. It's almost like you're gagging.
Can you take a deep breath for me?
Jesus, everybody's going to this concert tonight. I wonder if there's any decent passes left.
An interesting thing we look for when we check pupils is looking to see if when we shine the light in one pupil, that the same reaction's having in the other pupil, even though we're not shining the light on that. It signals that the neurologic system is working correctly. There's also something that we do when we have patients do the H maneuver, where we move our fingers around in an H and ask them to follow with their eyes. At the end, we actually bring the finger close to the eye to see if the pupils are able to accommodate.
Oh my God, Jenna. You're never gonna believe who DM'd me. I fucking told you this would happen.
I'm sure Jenna's happy you're here to support her, but perhaps you could wait outside until we finished.
I like the sets on this show. They're done very accurately. Glove placement, signage, bags, vomit bags. Feels like I'm in a real hospital.
I just really want to go home.
And that's the purpose of an ER, to stabilize the patient and have them go home. They should get follow-up care with a primary care provider, mental health specialist, etc. But the ER is not a place to just chill out.
Well, your vitals are excellent. When your parents arrive, they can take you. Thank you. Here if you need anything.
Good news or bad news first?
What's the good news?
Ear canal is numb. Simple flush with saline will fix the problem.
No way they numbed up her ear canal to do a saline flush. I'm not sure why they're doing a saline flush, but I do saline flushes all the time. I actually have a bigger bottle for it. I think it's called an elephant spray bottle or something because it looks like a big elephant ear that sits on the top of it. And we shoot it into the ear, usually with warm water and hydrogen peroxide to help melt some of the wax. And specifically warm water, because if you put cold water into your ear canal, you will get ridiculously dizzy for absolutely no reason and it'll be really uncomfortable. So We do that in order to clean out earwax if there is an obstruction, because it can make it very difficult to hear. There could be water behind that earwax, and as a result, it could lead to an otitis externa, which is an external ear infection. Now, what some patients do is they try and dig around with objects, Q-tips, etc. Never do that. That is terrible. There are actually drops that you could use. Speak to your doctor about them as a potential option to help melt the earwax and have it naturally come out. So when you're cleaning your ears, you're only cleaning the external part of the ears. And to say that you're numbing someone's ear in order to do a saline flush, in order to get rid of cerumen obstruction, wild. I mean, not wild, it's just like really aggressive for no reason.
What's the bad news?
You've got a dead bug in your ear.
Oh, that's fun. I'm a big fan of using alligator forceps for things like this, especially if I can visualize. We also have a very cool, it's called a curette. It's basically like a little plastic mini spoon, if you will. The ones we have actually have a light that attaches to the end of them, and they're clear. So the light ends up going through them and actually amplifying into the ear canal so you can have a really good visual. So sometimes I just use that to light up the inside of the ear, and then with the alligator forceps, I'm able to fish out whatever foreign object is in there.
Cockroach.
It was way too big. What's that Snapple fact where like on average a human eats 1 to 2 spiders a year?
Wendell Stone, 52, chief rigger from Pitt Fest. Isolated trauma to the left chest when a speaker tower came down on him. Looks like multiple rib fractures.
Rib fractures are really dangerous, especially when they come from blunt force trauma of that impact. Remember, mechanism of injury is really important. So if you're having a huge object fall into your chest, we expect that the ribs will get damaged. The ribs can then poke really vital structures, heart, aorta, which is a major blood vessel that comes off the heart, so it can create major bleeding. But it could also poke the lung. If you poke the lung, you can get a collapsed lung, also known as a pneumothorax. This is a traumatic pneumothorax in a situation like this. Breathing would be really bad in terms of patient not being able to take a full deep breath. There is also a unique condition called flail chest, where someone has enough ribs broken that the chest wall moves paradoxically. There's actually a cool video of it that you can see here.
No abdominal tenderness.
What do we got?
Jinx, you owe me a Coke.
Isolated chest trauma
Stop.
with...
I want to hear from Dr. Santos.
Isolated chest trauma with obvious flail chest.
Flail chest, we got another diagnosis, let's go.
No human pneumo on POCUS, good stats and vitals.
Excellent presentation.
See, in that presentation, if they were presenting to me, I would have liked to know a mechanism of injury, because off that mechanism of injury, I can make a decision about escalating care, increasing the acuity of the care, or decreasing it based on the severity. So for example, if someone trips and falls, hits their head, it's a very different proposition than if someone was in a car accident going 80 miles an hour and hits their head. So very different risk proposition in those scenarios.
Sir, I'm Dr. Garcia from surgery.
I need surgery?
Not necessarily. No blood in the belly on FAST.
FAST is an ultrasound scan that looks at blood in different cavities of the body.
Abdomen's benign. CT chest, abdomen, pelvis with contrast.
Exit!
And more morphine, for God's sake.
No. Don't knock me out. I gotta stay on top of the crew doing the pudding.
The what?
The festival.
We'll block all the nerves going to the broken ribs.
An easier way to explain a nerve block is to think about how we do it in a finger or a toe. So for example, if I needed to do a serious procedure on the tip of the finger, and I want the tip of the finger to be completely numb, I go below the area and I inject each side with numbing solution, lidocaine as a common one. When you inject it on 4 sides, you essentially create a barrier so that the nerve distal, meaning further from that point, has no sensation. And if you're doing a serious procedure or you have serious pain, it's not a bad way to go about pain control. It is temporary, obviously.
That's a ton of intercostal blocks.
Nope, one shot. Serratus interior blocks down to T9.
He's talking about, again, distal from where that nerve receives sensation, meaning further away, you will not have sensation. So he believes that if he blocks that one nerve, you will get no sensation from that entire area. However, it is very difficult to know which nerve is picking up on the pain until you actually start doing the nerve block.
You kids and your crazy regional blocks. Dr. Santos, call me with the CT results. Extension 1121.
Doctor, does that sound he's making mean it could be any minute?
No, that means he's having air hunger, or are they gonna say he's having, not diagonal breathing, not hexagonal breathing, agonal breathing.
No, it just means that he's having trouble handling his secretions.
To me, this feels like it's agonal breathing.
I'm also going to give you a scopolamine patch behind your ear.
Most people would know scopolamine patches from the treatment of motion sickness. It's an anticholinergic based medicine that essentially ends up drying patients out, so it decreases secretions. Similarly to how certain medications, like let's say Benadryl, can also dry you out. When patients overuse these, especially when they're sick, it can dry out the secretion so much that it can make it hard to breathe at night, block sinuses, etc. So you have to be judicial with your use of those.
Getting short of breath here.
Pain?
No, all that's gone.
Good. The block worked.
Sats are down to 85 on 5 liters.
His lung contusions need some help. Start BiPAP, 10/5. That'll open up the bruised parts of your lung.
That's very aggressive.
Good news is you don't need surgery, but I'll let Dr. Garcia know about the CT.
You got to be really careful when you think about artificial ventilation. Obviously, this is not like intubating him, but in general, whenever you're increasing pressures and if you do intubate somebody, you increase the amount of tidal volume, the amount of air you're delivering, or you change settings on the machine, like they're called PEEP, post expiratory end pressure. You can keep the alveoli open, but then if you stretch them too much that they rupture, you could actually cause the lung to fully collapse. Oh.
Damn, they woke the Kraken.
What's he do for his next round?
Is he detoxing from alcohol and is going through DTs and needs Librium?
40 minutes ago.
Perfect. All dead.
You caught me, and I was almost over the wall. Go easy on me, Warden.
I need an order for an agitated psych patient. Been here for days. Methamphetamine-induced psychosis.
The Kraken?
Really should call him that. I'm about to be 52.
No. That would take way too long. Type the staff. QTC?
Normal.
QTC is a specific part of the electrocardiogram rhythm that can be prolonged with certain medications. So if someone already has a prolonged QTC interval, that puts them at high risk for widening that QTC interval, which can lead them to a dangerous, unstable arrhythmia, potentially to their heart stopping. A common medication that people don't realize that can actually widen your QTC is called Zofran, which is an anti-nausea medication, very commonly used in IV drip spas when they come over to your house for hangovers. And last I checked, those companies that are doing that are not doing a preliminary EKG to check if you have a prolonged QTC interval. So you could see my worry about that.
5 of bedazolam, 5 of Haldol, and Mr.
Kokosia.
You're joking.
No.
Mr. Kokosia will be out like a light in under a minute. It hardly seems as offensive to call him Kraken if his name is actually...
Irritable 5-month-old.
Clearly, I'll be right there.
Any fever, vomiting, or cough?
None of that.
Good feedings?
Was she full term at birth? Normal delivery. Childhood vaccines? 2 months and 4 months.
Yeah, these are all really good questions. You really have to get a lot of info very quickly in deciding what to do in pediatric emergency cases.
What's your differential diagnosis?
We need to check with a rectal thermometer.
Is that really necessary?
Yeah, the rectal thermometer gives the most accurate temperature.
It's really important.
Heart rate 164, stats 99.
This is Dr. Robbie, our senior physician.
Hi, nice to meet you.
Afebrile alert, good vitals. Doctors Mohan and King were just about to start their physical.
One of the most important vitals that you do on a child is their breathing rate, because when a child is struggling to get air, they will start breathing very rapidly, and that's a sign of deterioration. They do something known as grunting, where they struggling to get air. They start using accessory muscles, like their upper neck muscles, or you see actually rib retractions where they're like struggling to pull air really bad, and that can happen during times of infections. Like very commonly we see with RSV as a viral example.
Why is she still crying?
Fontanelle is soft and flat.
Flat fontanelle is the little soft spot that you see on infants' heads. If that fontanelle is very sunken, that can signal that the baby's dehydrated. If it's very full, that could be a sign that there's some kind of pressure process going on, increased pressure process going on inside the skull. We call it a bulging fontanelle. I don't know why I just went blank on words.
Mucous membrane's nice and moist.
Moist mucous membranes, again, signify that the baby's hydrated well. One of the tests that we do is we check skin turgor, where we literally lift up the baby's skin and see if it rebounds nicely. Dry skin, meaning a dehydrated baby, that does not happen. As we get older though, that test is not as useful because our skin starts to lose a little bit of collagen and elasticity. baby. Another test that we do is called cap refill, where we put a little pressure on the nail bed. We see it blanch. When it blanches, meaning it turns white, we let go and it should refill within less than 2 seconds. That's a normal cap refill. Also signifying that there's good blood pressure, good perfusion, and that the baby's well hydrated.
Lungs are clear. Heart rate's tacky but normal.
Soft abdomen, no obvious signs of tenderness.
So basically a normal exam.
Then what's wrong?
The mom could be undergoing some kind of mental health process here, and that's worth evaluating with a talk with her while the baby's under another doctor's supervision.
What am I looking for, Dr. King?
Cellulitis, edema from dystotic syndrome.
Diagnosis made. What is it?
Hair tourniquet.
Mother's wet hair can wrap around the toe multiple times. When it dries, it tightens and cuts off circulation.
My hair? I showered before nursing her.
That can happen with anybody.
But we caught it early, so there won't be any permanent damage to the toe.
Treatment, Dr. Mohan?
It's too tight for scissors. Do we have Nair?
We do indeed.
Nair? Like from the drugstore?
10 minutes should dissolve it right off and stop the crying.
A little Nair goes a long way.
What's going on?
Hypoxic to 78, BP's crashing, systolic's 82.
Pulse is thready.
Pulse is thready means we have a weak pulse. He's desaturating, so not getting oxygenation. Something bad's happening.
Absent breath sounds on the left.
Absent breath sounds means that the lung has collapsed.
Tracheal deviation to the right.
Tracheal deviation means that the lung has collapsed so significantly that it's actually moving the trachea to one side because pressure is building up on one side. So usually in a situation like this, you need to create an opening.
14 gauge angiocath. Now, put him on a non-rebreather.
In an ER setting, they'll usually place a chest tube. In the field, sometimes just a needle is used.
Tension pneumothorax from the BiPAP's positive pressure.
This is really rare, and this has never happened to me, but when you see someone who's on BiPAP, you could see that it's putting pressure into their airways. And when you increase the inspiratory pressure too high, it can cause what's known as barotrauma, actually make the alveoli stretch so aggressively that they burst, and you get this tension pneumothorax. There's that needle going in and releasing that pressure. He should start feeling better almost immediately. Then they usually put a residual chest tube in order to let that area heal fully. Because remember, for the lungs to be able to fill, you actually need negative pressure inside your thorax, inside your chest cavity. Imagine air is being sucked out of your thorax so that the lungs are expanded. If you lose that negative pressure because there's pressure building up because of an injury to the lung, the pressure starts pushing the lung in and moving everything to the side, therefore not allowing that lung to reinflate. So the loss of negative pressure is an issue.
Who the hell ordered BiPAP, Garcia?
No, his sats were down. I did.
You did. Without running it by me.
Can I put in a chest tube?
He doesn't need a chest tube. He needs a pigtail catheter, and I'll be doing it.
Sats and pressure both coming up.
Whoa, what did I miss?
A little drama from a tension pneumo.
You could have called me.
We got it under control.
Good.
And Dr. Santos learned what can happen when you put a patient with a small pneumothorax on BiPAP.
There's certain medical conditions that predispose patients to having barotrauma from breathing treatments. ARDS is a very common one, COPD, fibrosis of the lungs, etc.
You need to run every order by a senior resident or attending.
That's why it's a 4-year program.
Now, when you do this procedure, you want to make sure to never, ever lose this guide wire. If that gets sucked in the chest, you're screwed. Now, ready for the pigtail.
What the hell are you doing? Pneumo is tiny. It'll resolve spontaneously.
Yeah, it was tiny until the patient went on BiPAP.
Are you kidding me?
They curse a lot on this show.
His sats were down. I gave the order.
Without clearing it with me.
Honest mistake from the rookie. That's how we learn.
Yeah, the issue is not that she recommended something as a mistake. The issue is that she did it without asking, and that's the bigger problem here.
Guys got some energy.
Let's do this. Donahue, right leg, Larry, left leg, Kim, right arm. I call left arm. Perla takes the head, and our young man here will inject. Clear?
Yeah.
Pulse ox?
Right here.
Good luck.
I am injection to the mid-anterior left thigh. Everybody ready?
Yo, Whitaker, Larry and I gonna block for you. Come in right behind us. When we split and go for his legs, you go right up the middle. End zone, baby.
Okay, yeah, got it.
Isn't he secured with soft restraints? Why are they panicking right now?
1, 2, 3.
Okay, Mr. Krakosia, we're here to help.
I'm surprised they're letting the med student do the injection. I feel like he's gonna stab himself or someone else. Or something bad is about to happen.
Oh, God.
What do I do? No!
Oh my God, please don't tell me he hit his femoral artery. And he went medial thigh, not lateral thigh?
Congrats, kid. You just earned your yellow wings. Okay, midazolam will take him down in a minute. We'll monitor him for 20. After that, the Haldol will have kicked in.
That's a benzodiazepine in order to calm him down. Handling sharps in that environment is very, very dangerous.
Thanks for your help. Go get cleaned up.
Sorry. Yeah, thanks.
Can I help you get new scrubs?
Oh, no, it's good. I'm gonna...
And he also got bodily fluids on him, especially with an open wound on his finger. You got to be careful with that.
Tomás Cordera, Mr. Tomás Cordera, please come to the window. I have your insurance card. Tomás Cordera. Yes?
Cordera. It's actually Tasha Cordera. And Miss.
Okay. You want to come on back? Go through those doors? You cut your arm?
Yes.
Okay, no problem.
Hi, I'm Dr. McKay. This is Victoria Javati, student doctor.
I love when people introduce med students as student doctors as opposed to just student, because it gets them used to being called doctor. It's a good part of the learning process.
Sorry for the long wait, Tasha. Do you mind if I take a quick peek?
Yeah.
Okay.
They're doing this in the hallway?
All right. Not too bad. Definitely gonna need a few stitches, though. Why don't you come on back and we'll get you patched up.
I think a reasonable question is here, how did that happen? Because if there was self-harm involved, you want to be aware of that.
So, Tasha, it was a decanter? A beautiful Baccarat carafe. I was showing a colleague how to polish it, and the neck broke with my arm still inside. So, not my finest.
Did it shatter?
No, it cracked cleanly in two, but as a reflex, I jerked my arm back. That's what did it.
Reflexes. I have regretted a few of my own. Good. Now inject to the other side.
So they're numbing up the site before doing sutures. This is a great time for a junior resident, sometimes a medical student, to perform the procedure under careful supervision, only with the patient's acceptance.
Looks good.
Nice job, Doc.
Thank you for the trust. Now keep it clean and dry, and we'll see you for a wound check in 2 days.
Keeping it covered is most important. In a situation where you have an open wound, keeping it covered protects it from infection, but also keeps an environment that's ideal for healing.
Sutures out in a week, but come back sooner for any redness, fever, or drainage.
Because that could be a sign of cellulitis.
I couldn't help but notice there's a misgendering error on your chart. I'm really sorry about that. I've gone ahead and fixed it here and on your insurance data file, but it shouldn't happen again.
Wow. Thank you.
That's kind. Our new electronic health records, like the one I use is called Epic, they have an area for patients' gender, orientation, their preferred pronouns, their preferred name. It facilitates good doctor-patient communication so that you're never making a patient feel unwelcome. You always want them to feel safe. And part of that is respecting the patient's identity. And also, one of the most overlooked things is patient preference when it comes to language. Because while some patients are able to speak a language, their preference is to speak another, and you should be able to respect that, especially in the day and age where we have interpreters through iPads and such, like we did on the last episode.
Hi, I'm Dr. Mohan.
Hello. Nice to meet you.
Jiayi is a 12-year-old with 6 weeks of constant pain in the suprapubic area.
In a situation like that, you're right away thinking about the pelvic organs. 6 weeks is a long time to think for urinary tract infection, but generally speaking, suprapubic tenderness usually means something to do with the bladder or perhaps the uterus.
There's no fever, no dysuria, no nausea, vomiting, diarrhea, no vaginal discharge, and the urine pregnancy test is negative.
All important things to check.
A pregnancy test? Of course it's negative. She has a stomachache.
We always check a pregnancy test in someone who is of childbearing age because those symptoms can sometimes be very quickly treated. New pregnancy can present itself with a lot of nonspecific symptoms: nausea, abdominal pain, vomiting, headaches, very benign symptoms that you might attribute to something else but could be explained by pregnancy. And the treatment for those things needs to be taken into consideration whether or not the patient is pregnant.
Tell me a little bit more about your pain. Can you give me a number from 1 to 10, 10 being the worst?
It was like a 2 the first few weeks. Then it went up to a 5. Now it's worse, like a 7.
And when was your last menstrual period?
Haven't had it.
This month?
No, never. A few of my friends got theirs. I'm still waiting.
She's only 12.
That is the time that you would expect someone to get their first period, but it doesn't mean that it definitely should have happened.
Okay, we'll be back for an exam. Why don't you change into a gown, open in the back?
You also have to think in a situation like this, there's a parent who is being somewhat proactive in the conversation. The child is being a little timid. Is there any kind of foul play involved, mistreatment, etc.?
No period, but she has early secondary sexual characteristics, breast development, widening hips.
Yeah, it's primary amenorrhea.
They're talking about Tanner stages, which is how we decide the development, the sexual hormone development of a child.
Soft, non-tender.
Okay, Jay, we're gonna check below the waist. You'll be all covered up. Would you like Dad to stay?
Yes, please. Don't go.
Okay, I'm here. I'm glad that they have the curtain closed. In their scenario, they definitely have the curtain closed because the door behind them is glass. But for example, in my exam rooms where the door is solid wood, a lot of people think door is shut, it's good, but it's very possible someone to walk into the wrong room, and then as a result, the not necessarily the child, but the patient can be fully exposed. So it's good to have a secondary barrier in between, like a curtain.
We're just gonna take a quick look.
You'll feel me touch your upper leg so we can see where you pee. Any pain?
Having this type of dialogue and always maintaining visual of the patient's appearance is very valuable, so you could see if they're uncomfortable, if any pain is happening, etc.
No, it's okay.
Foreign object, infection, what's happening?
You did great, and we know how we can help you.
Thank you.
Dad, can we step out for a minute?
How did she diagnose it that fast?
Yay, good job.
Great teamwork in terms of making the child feel comfortable.
What's wrong with her? Her mother died of colon cancer. Is it?
No, that has nothing to do with this. Do you know what a hymen is?
Does she have imperfinite hymen?
Not really.
When the baby's developing in the womb, there's a membrane called the hymen which blocks the vaginal passage. Before birth, most of it goes away, but sometimes it doesn't.
And when it doesn't, it still usually has an opening to allow the period to come through, but that opening is not present at all times, and there's actually variations to how that opening can present itself. So the menstrual contents can actually back up into the vaginal canal and potentially even into the area of the uterus.
Is that dangerous?
No, not at all.
Usually very easy to treat. Just create the opening.
The good news is that your daughter has an imperforate hymen, totally blocking the vagina. We saw what looks to be about 3 months of violaceous menstrual blood bulging from behind it.
Oh my God.
It's totally curable and an easy fix. Your daughter needs minor surgery, best done under anesthesia in an operating room by a gynecologist.
Then she'll be okay.
Yes, totally back to normal.
See, I would not venture to make all these statements about it being totally normal because you don't know what's behind the menstrual contents. You can't visualize it. You haven't yet visualized it. So you don't know what's actually there. So you could say like, this is what makes sense for now. Once we are actually doing the procedure or our colleagues are doing the procedure, we can then figure out what the exact diagnosis is, because even when we write our procedure notes, we have our preliminary diagnosis and then there's like a post-operative diagnosis to see if it matches, because sometimes it doesn't.
Is he still with us? Those are called agonal respirations.
I guess we were just a little bit too early. I really called them a hexagonal respiration.
Close to the end.
And this is where you do a final exam and call a time of death. And then I don't know what the rules are based on Pennsylvania code, but in our hospital, we would do a call to the medical examiner and explain what happened. Usually they just say, okay, here's the code, etc. But sometimes if there are unique circumstances surrounding the death, they will actually investigate. Checking for a pulse. Listening for a heartbeat. Checking pupil reflexes, pain tolerance, pain reflex. Sometimes they do a corneal reflex. The reason he's listening so long is because you have to listen for an adequate amount of time to confirm that you haven't heard lung or heart sounds. The human body is pretty amazing, and sometimes the human body can survive some pretty intense accidents. Click here for a full video on that, and as always, stay happy and healthy.